So let's talk a little bit more about how iodine works in the body. And this will answer some of your questions that I was getting at the break. So you can have a normal gastrointestinal absorption of iodine, but effective retention system. So you have a sodium iodine symporter defect where it's not able to transport iodine across the cell. You can have congenital defects of that. It's rarely reported in the literature. What's not rare is this oxidative damage problem that's from fluoride and perchlorate. And you're going to treat an oxidative problem with an antioxidant. You could also have an inhibition by iodine uptake by competition, such as a goitrogen binding to a receptor. Only iodine can overcome that inhibition. Bromine is something that'll do that. In this case, that iodine loading test will come back over 90% excretion, and you're going to be told you have a normal loading test. When you know, if it's for you, that it can't be normal, you're not taking iodine, or your patient who's sick and not taking iodine, you just know that they're not right. The way you spot defects in that test is these are the non-responders. These are the people who get adverse effects when you give them the first dose or two. Some adverse effects might be, we'll talk about that at the end, palpitations or nervousness or jitteriness. These are the people that have high iodine, which is read as normal, but when you're not expecting it and you don't believe it. So if it's a sodium iodine supporter defect and it's a genetic problem that you're born with, I don't know what you do with that. It's rarely reported in the literature. However, if it's an oxidative problem, give them an antioxidant. If it's a goitrogen binding to the receptor, you got to detoxify them and competitive inhibit. What are you going to competitive inhibit with? Iodine. Salt is another one to help competitively inhibit whatever's binding that receptor, unrefined salt. Now, here's a study that with Dr. Abraham. On the orange is 6 female patients who took 50 milligrams of iodine here, and then we measured their serum iodine levels every hour or so, 8 hours and 24 hours. And you can see these 6 follow this nice normal curve. You remember my nurse, Denny? I told you what to remember her. She was above that 90%. Denny's got Graves' disease. She works in my office. I did that loading test on her. She came back over 90%. There's no way Denny was over 90%. She wasn't taking iodine. There's just no way. I didn't believe it. So what we did was we gave her another loading test, and we drew her blood every hour. And here's what happened to her iodine levels. The first hour and a half. And then 3 hours later, she's pretty much down and out. So we know she absorbed it because it got into her bloodstream. And 3 hours later, she kicks it out. So what would you think is Denny's problem? No retention. That's right, no retention. But what's causing no retention of iodine? Someone raise their hand. Competitive binding, maybe. What else? No, I don't think it would be T4. Why isn't the iodine binding? Why? So the symporter is damaged. It's not taking it up. So we could have the symporter damage. We could have competitive inhibition. Either way, you're still going to see the same problem with her. So at the same time we did this test, because I knew she had a problem, she was also, when she took that first dose of iodine on the previous test, she got palpitations. She got jittery. She got irritable. So we redid the test. We also drew her bromine levels at those. We checked her bromine levels out of the same serum sample. Now here's time 0 before we gave her iodine. 200 is considered near lethal level. She's walking around with 150 milligrams per liter of bromine just in the clear. We give her 50 milligrams of iodine, and her levels shoot up. It is like Africa in here. African hot. So she shoots up to near lethal levels of bromine. What do you think she's telling me here? What was she telling me? I'm going to kill you. What did you give me? I feel lousy. I don't know if I can work today. It was a long day. And, I'm miserable. My eye hurts. My head hurts. So we followed her iodine levels her bromine levels. Okay, so now, why is she getting that iodine kicked in and out? What do you think now is wrong with her? You gotta raise hands. What's that? Shout it out. So the bromide's displacing the iodine. Very good. And the bromine can also cause some damage to the, bromine's a very oxidative, could be oxidized very easily and cause some damage. So we diagnosed her with bromine toxicity. You're right. What would you give her for this? Okay, iodine. She won't take it. She's miserable with it. She ain't taking iodine. What else would you give her? Salt. Salt's a good reason. Salt is the old remedy for bromine toxicity. That she's miserable when she takes this iodine and she's got this bromine toxicity, so probably oxidative things going on here as well, oxidative damage. What else would you give her besides salt? What antioxidant would you give her? Selenium, vitamin C, your choice. We gave her vitamin C. So what we did with her was we gave her 3 grams a day of vitamin C. We put her on 10 grams a day of unrefined salt. She wouldn't take the iodine, and we retested her again. Here's her test again. And we gave her 3 months of the salt and vitamin C. That's all we did. We tested her again. Now, she's got a normal curve. So whatever, this N of 1 goes to the heart of why we're all here and why you went to be nutritionists and osteopaths and holistic allopaths and chiropractors. And did I miss anybody? Who did I miss? Holistic dentists. Actually, we need holistic dentists. Holistic dentists are few and far between. Regular dentists have done a lot of damage out there. Not that my profession hasn't done a lot of damage, but boy, regular dentists have done a lot of problems to people. How did I arrive at 10 grams of salt? Because I started using unrefined salt years ago. I started having people use about a teaspoon to 2 teaspoons a day. It measures out, teaspoon and a half measures out around 10 grams, and I just took a guess at it. That's how. Do you guys measure anything in teaspoons or teaspoons? I was in middle school in the 1970s, and we were going to switch to the metric system, and everyone was throwing a fit. We don't need to switch to the metric system. Jimmy Carter was the president. That's what he wanted to do. And, they abandoned that shortly thereafter. And every once in a while it'll come around again. We need to switch to the metric system, and the whole country goes in an uproar over it. Like, it's such a big deal. Anyways, so here's this N of 1 showing why we're all here. We used competitive inhibition by putting her on salt and chloride. We used antioxidants and vitamin C showing an antioxidant effect, and we normalized a iodine ingestion curve in one patient. And I say that there's no drug that could do this. This really talks about what we're all reading in the journals and trying to do with our patients. And, it's a very powerful N of 1 that, in thinking through it, that was my thought process just as I went through it with you guys and, when I was going over it with Dr. Abraham. So when there's problems with iodine, think detox, salt, have them hydrate, liver and kidney support, have them exercise, clean up the diet. Of course, it's good for everything. It's particularly good for this too. If they get into problems when you take iodine, especially with the first dose or two, stop them, take them off it, do all this stuff as best you can, and then have them restart it a month later. Many times that'll get you out of trouble with it. There is a saliva serum iodine level. I talk about it in my book. I don't have time right now. So I'm going to pass over this. Although I do have an interesting story with it. So you can check the saliva serum iodine level. And the sodium iodine symporter is not only in the thyroid gland, it's in the salivary gland. So it concentrates iodine into the saliva against the gradient. This test is done today in neonates in the hospitals who have all the neonates in the U.S. and I'm sure in the U.K. are tested for thyroid, right? I'm sure they're tested at birth. No? Really? So every neonate in the U.S. is tested for thyroid. So if there's a problem with this test, they will do this saliva serum test. And what they do is they inject radioactive iodine into the baby and then see how much iodine concentrates in the saliva versus the serum. So normally it's reported in literature as over 10 in the saliva and the serum is normal. 3 to 10 is borderline. Less than 3 is abnormal. Now, we can also do this test, and I've done this with Dr. Abraham, and I've done this in my lab. So if the ratio is near 1, it would indicate you got a defect in transport. You can't move iodine across the cell into the saliva. Is it a symporter problem? Maybe. There's other symporters which I can't get into. But as the ratio increases, it indicates an improvement in iodine transport. What we found is normal is not greater than 10. Normal is in the 40s, around 45. Tom is another nurse of mine. He's 42 years old, grams, which is 2 of these iodozyme HP tablets a day. And he was feeling better on the iodine, but he was still dragging at the end of the day and tired. And so I had Tom go to 50 milligrams per day. What do you think his saliva serum ratio is going to do when he ups his iodine? Go up, stay the same, or go down? Go up. He's going to concentrate more. Oh, here's his saliva serum ratio of 12.5 milligrams per day. Here's a 50 milligrams. He felt better on this than not taking it, but he felt really good on this. Now, what do you think his bromide levels are going to do when we? They're going to go up. After we did this, we checked his bromine levels, and here's his bromine excretion levels. This is marked high. So even at 12.5 milligrams, he's walking around with too much bromine. And look how much he goes up. He quadruples his iodine, and he, what is that, 40 to 120. He triples his bromine excretion. Now, he felt good here. There's a lot of people that don't feel good here, and they feel palpitations, nervous, jittery. If they do, you need to stop it, support them with salt and vitamin C and selenium and whatever else you want to support them with, and then restart them again in a month. Now, this is why I wanted to take. Here's the whole cliff note part of it. I explain this more in my book. Here's the membrane of a thyroid cell. Here's the serum. Here's the symporter. This is like a little car that transports iodine across the cell. Iodide across the cell into the thyroid cell. These things are made in the body by TSH. Who's using iodine? Who's prescribing it for patients so far? What's the first thing you see on the blood test after you give them iodine that might cause you a little concern at first? TSH goes up. Why would TSH go up? Well, TSH goes up because the body is not stupid. It's not going to waste energy making things it doesn't need. If you don't have iodine in your body, it ain't going to make these symporters because there's no reason to transport lack of iodine into there's no iodine for it to transport. So one of the first things you'll see when you give them iodine is TSH will go up to stimulate symporter. TSH, how much do you see TSH go up when you give them iodine? To what? 5. Who else? 5. She's got 12. Who else? Give me another number. Anyone who's monitoring this? So 5 to 12, I would agree with you guys. That's exactly what I see in my practice. It can go up to 5. It can go up to 12. I've seen it go up into 20s, low 20s. Generally, if they're feeling good, and to be sure, you can check a T3 and T4 level. If those levels are fine, they are not becoming hypothyroid. They are making symporter. It's a normal phenomenon. Unfortunately, if the endocrinologist sees it and Dr. Vader gets a hold of it, he will cause you problems, and you don't want that. So you have 2 options when you put them on iodine. 1, don't check their TSH for 6 months, which is the best option, and tell them not to have it checked. And number 2, if you check it, you have to check a T3 and T4 with it to cover yourself. And then document that you see them back and do a exam, and they're not hypothyroid, they're not hyperthyroid, and they're feeling good. That number usually go down within about 6 months in the vast majority of people. They don't need more thyroid hormone. They're not hypothyroid. They're normal. They're just making more symporters. So iodine is now transported across by the symporter into the thyroid cell. It has to undergo oxidation. via hydrogen peroxide and thyroperoxidase. This oxidation takes iodide and oxidizes it to iodine. Remember, iodine didn't have that extra electron in its outer shell. The purpose of this is that the intracellularly in the thyroid and other tissues, you need iodine to undergo organification. Iodine does not undergo organification. Only iodine does. And organification means it binds to tissue. It binds to thyroglobulin, not tissue. It binds to other cells. And at the RDA for iodine, that rat's dose of, what's the RDA? 150 mics, around there, you will form thyroid hormone. Enough thyroid hormone, and you won't get goiter. If that's what you want to do, that's fine. Then give them enough that the rats need. But at 100 times the RDA, which is about 15 milligrams, you can produce these iodinated lipids. One of them is called delta-iodolactone. And that may be a beneficial thing to do, and I'll show you that in a second. But you're only going to get organification of lipids in excess of the RDA, or RDI that they're calling it now. I haven't come up with a good acronym for RDI.
Rats, drugs, and idiotic, or rats, drugs, and idiopathic.
Rats, drugs, and idiotic is not so bad. I didn't think about that. Rats, drugs, and idiotic.
Ridiculous daily intake.
I like that better. Ridiculous daily. I might have to write that one down. Ridiculous. That is a good one. And what was the other one? Rats, drugs, and idiocy. Rats, drugs, and idiots. I'm going to have to figure out which one I'm going to use. That's coming home with me. So here's the formula for delta-iodolactone. About this at lunch. You need omega-6 fats in your diet. If you take too many omega-3s, you're not going to make any of that. And delta-iodolactone is a key regulator of apoptosis and cellular proliferation in the thyroid. It's not detected in human tissue when iodine deficiency is present, but is present with iodine administration at least 100 times the RDA for iodine. So it's a pretty important substance that you want in your thyroid. Now, with low iodine, is a chemical they'll give animals to induce thyroid tumors. And MMU-induced tumors contain 4 times more arachidonic acid than normal mammary glands. They induce it for thyroid and for mammary tumors. Iodine supplementation is accompanied by 10-fold higher delta-iodolactone content in tumors. The same research shows that delta-iodolactone and iodine have antiproliferative and apoptotic properties. So you can't really utilize this arachidonic acid unless you have iodine and this delta-iodolactone coming together. Affect the cell, this organified iodine in these 2 cell cycles. So let's take this step a little further. We've got times the iodine, you form this delta-iodolactone. Where does it all come? How does it work before that? Well, the peroxide is supplied locally by oxidative phosphorylation and the NADPH oxidase system. What's the rate-limiting step for this thing? What's NADPH stand for? Niacin. So the brake on this pathway is iodinated lipids provide a brake here. Calcium stimulates it. You can see what happens now if you're not going to give enough iodine. Now, here's if iodine levels are too low. Too low of iodine, oxidize it. Now, you're going to have decreased organification, and you get screwy thyroid hormone levels. If you look closely at those T3 and T4 levels, you will see, in this case, the T3 is a little bit elevated compared to the T4. Who's seen that? I never knew what it was. Did you ever know what it was? Years I never knew. It always bugged me when I saw it. They're all in the normal range, but T3 would be up here, T4 would be here in sort of those normal ranges. I thought, come on, that's not right. There's a conversion and all this, and I never understood it until now. It's an iodine deficiency problem. You'll see it in the vast majority of patients that are iodine deficient once you start looking for it. So, now remember, we have decreased iodine now. So are we going to form delta-iodolactone? No, we're not going to form it in any appreciable amounts. So what's going to happen with this NADPH oxidase system? Are we going to have the break for the iodinated lipids? No. Everyone's taking calcium, and there's too much calcium in the diet and supplements. And temporarily, they get excess peroxide formation, and they start to get an oxidative reaction going on inside the thyroid gland. What's the first sign you're going to see when this is occurring in blood work? Very good. Antibodies. This oxidative stress is going to start damaging this. So what's the body going to try and put out? And this is a very oxidative. Once this molecule is activated, it's like, roaring fire in the thyroid gland. What's the body going to try and put out that oxidative fire with? Antibodies, anti-TPO antibodies. So the first thing you'll start to see is anti-TPO antibodies. As this starts damaging thyroglobulin, the body's going to try and put it out with anti-TPO and anti-thyroglobulin antibodies. This is the whole mechanism of autoimmune thyroiditis. So, what's going to be the treatment for this? Iodine's going to be one thing. What else? So, selenium's a good action. We're getting oxidative damage. Antioxidants, good choice. Niacin would be another good choice. You guys are getting it all. Magnesium to counter some of this excess calcium. Niacin and riboflavin are helpful. Selenium, other antioxidants. It needs to be part of a comprehensive holistic treatment regimen. I describe this much more in detail in the book. But this sort of gives you the overall view of, hey, autoimmune thyroiditis is iodine deficiency driven. It's not iodine excess driven. Now, here's the breakdown of hydrogen peroxide, glutathione peroxidase. Breaks it down into water molecules. What's this enzyme? What's the rate limiting? It's a selenium dependent enzyme. What else is it dependent on? It's selenium and it's glutathione, but it's magnesium is another dependent molecule for this. So a little bit of selenium helps with it. A little bit of magnesium can also help to supply the right nutrients to break down the peroxide. 54-year-old male, poor concentration and energy fluctuations of brain fog. He's taking 150 milligrams of a combination of iodine and iodide per day. He's somewhat improved. It's Lugol's. Lugol's is liquid form of this. But Lugol's is hard to get. And this is the iodozyme HP is appropriate for this. His loading test improved from 15 to 55% after 2 years of taking over 100 milligrams of Lugol's. However, he began taking course of his first dose. All the symptoms of brain fog cleared. His concentration improved. His energy normalized. He told me, I've never taken any medication or supplement that had that dramatic an effect. It's my partner, Dr. Ng, who's got Hashimoto's disease. The only thing that lowered his titers were high-dose iodine, and then when we added B2 and B3, really that made the big difference for him. Okay, so how do you dose iodine? Iodine, Lugol's is tableted Lugol's. So 12.5 milligrams is one pill. And therapeutic doses vary between 1 and 4 of these a day for the vast majority of people. If they have breast disease, if they have prostate disease, if they have thyroid disease, ovarian disease, generally they'll need more. So in medical school, we used to order these radioactive iodine uptake tests. You inject someone with radioactive iodine, you see how much thyroid uptakes. Normally it's reported that 12 to 30, I think it's 35% are normal. So I used to, when I rotated through endocrinology with Professor Vader, as I remember him, we were looking at these radiologic tests of the thyroid gland. And I used to say to him, well, why is 12 to 32% radioactive iodine uptake normal? He says, because that's normal. I said, well, I wouldn't want radioactive iodine uptake by my thyroid gland. Shouldn't it be 0? And he says, no, it's 12 to 32%. That's normal. I said, why? Because it's normal. So that was the end of my, and I wasn't interested in holistic things at that point. I didn't learn about it till Dr. Abraham, and I started working together, and he put this together. So how much iodine do you need? You're exposed to radioactive iodine or injected with radioactive iodine, 0 accumulates in your thyroid gland. That means you got enough iodine there. It's just going to pass. Okay. Saxena did a study of captive medical students. He gave them 3 to 5 milligrams of iodine per day, and he checked their radioactive iodine uptake, and their absorption went down below 5%. Remember, normal is 10 or 12 to 35%. So, this is Sternthal, another study of captive medical students. Over 12 days, he gave them varying amounts of iodine. The radioactive iodine uptake went down. The more iodine you gave them, bound to the thyroid, you give them radioactive iodine, it just passes through. Everyone with me? Yeah. This is Dr. Abraham. And what he did was he plotted on the x-axis the daily iodine intake. On the y-axis, 24-hour uptake by the thyroid gland. So you can see as you take more iodine, you get less radioactive iodine uptake in the thyroid gland. He just took these numbers and plotted them, right? On the z-axis, the amount retained by the thyroid gland. So he used other data, other studies. The more iodine you took, the more that went in the thyroid gland up to, here's our 600 micrograms. So, where do you want to be on this graph? Between 10 and 100. He's right. Somewhere here. You want maximize what's uptake by your thyroid, minimize radioactive iodine. Is it 50? Is it 75? Is it 100? Is it 200? I don't know what it is, but it's certainly over the rat's doses, which is over here. Here's the RDA. I love when they hit that evidence-based medicine hammer out and say, oh, there's no evidence to support what you do. There's no more evidence in this graph of what we're doing. I never understood this graph when Dr. Abraham first put it together. And I looked at it, and I looked at it, and this is when I was new to working with him, and I used to call him up, and I'd say, I can't understand this graph, Dr. Abraham. And he's explained it to me, and the third phone call, he was annoyed with me, and clearly in his tone with me, haven't we already gone through this, Dr. Brownstein? Yes, but I can't understand it. You go through it again. It took me about 5 or 6 phone calls, and then I was flying to Hawaii with my family, and on the plane ride, I got it. I stopped in San Francisco, called him from a phone, and I said, hey, I got it. And he said, well, good. Now we can move on to something else. But I explained it to you so you don't have to have trouble with this graph. But this graph goes to, the heart of why people need milligram, not microgram doses of iodine. Here is the saliva serum ratio. I don't need to go through that one. So the iodine dosage per day, it's inadequate. The dose must be individualized. Use a combination of iodine and iodide. Iodozyme is an appropriate product, but you can also do appropriate pre and post testing and get your levels checked. I don't think when you're first new to this, I would suggest for you to check your first 6 or 10 clients or patients, and so you get a good feel for it, and certainly check yourselves, especially if they're offering a deal for it, so you can get yourself ortho-iodo supplemented and feel better, and then you can help your patients with it. So I can feel medical iodophobia waning, and the final thoughts is to keep salt. And I was told you guys don't iodize your salt here. Less than 1% use iodized salt. Iodine deficiency is the underlying cause of autoimmune thyroid disorders, and using a combination of iodine and iodine is more effective than using iodine alone. But the best results are achieved with a comprehensive holistic approach where iodine is part of that. You can't balance the hormonal system, and the whole body sufficiency generally requires higher doses of iodine, somewhere in the milligram range. Let me just cut out here because I got 15 minutes, and I want to just go through a couple of other things. I don't really have time to cover the autoimmune thyroid illness. I'm going to say that one slide covered it, And there's more in my book if you're interested in it. I gave you notes on it.
Yeah, you said something about the difference between omega-3 and omega-6. You said about the importance of omega-6 to omega-3.
Oh, we don't want to get into that now, shall we? But
well, do you take flax oil or hemp oil then? Which do you do?
I am not a big fan of omega-3 supplementation alone. People need omega-6 fats, and they need a balance of omega-6 to omega-3s. And if you're just supplementing with omega-3s, we see big problems with it in our practice. Let me leave it at that. I want to do a whole newsletter on that. I gave you a newsletter flyer if you're interested on that. And who knows, maybe that'll be a book in the future. But let me go through just a couple other slides. Okay. Everyone's afraid about using iodine for Graves and Hashimoto's, that you'll make it worse, and the Vaders of the world, the Professor Vaders say it. This next slide will prove to you that that's not true. Okay, here's a letter. This patient is a doctor's wife, and those of you that treat doctors' wives know they never do well with anything. There's always complications and always horrendous patients. Doctors' families are not great. I agree with that. Doctors, right. I from a patient, and I was seeing her for Graves' disease, and I went to which she was very low, and I said to her, "Are you sure, Dave, she needs iodine? She has Graves' disease." I'm like, "I'm sure." And he goes, "Okay." And so we put her on iodine. This is a letter I get from our mutual patient. I saw Joy today for follow-up. She's doing incredibly better. All those subtle changes related to Graves' disease, lower lids are may in fact only have a partial familial component. I'll reevaluate her after the holidays, but to hold to her that she continues to be educated. This is iodine. Okay, Tracy. She's holding a 3-month-old baby here. She's going to her doctor saying, I can't make my kids' lunches anymore. I don't know who's who. I can't go to the grocery store. I forget what I'm going to get. I get lost driving home from the grocery store. Something's wrong. So he does a thyroid test on her and gets that TSH. And what does he put her on? Thyroxine. She treated with Synthroid. TSH goes down to 1. And I'm going to have you just look at her face here and then look at her face here. Does she look better here? No. She goes back to her doctor. I can't make the kids' lunches. I'm getting lost at the grocery store. I feel terrible. I'm depressed. Same symptoms. What's he going to do for her now? He puts on an antidepressant. She takes 1 dose, feels worse, gets a hold of my iodine book, comes to see me. So I put her on iodine, changed her over to desiccated thyroid. She's got Hashimoto's disease as well. So TSH falls, but look at the difference. Look at her hair. So she went from here not being able to think at all. Now she does a thyroid support group online, and she's got hundreds of people that she keeps track of, and just the power of iodine, the power of treating this stuff. Hashimoto's and Graves' disease is not iodine caused, it's iodine deficient caused. Okay, so there's bromine in food. I said it's in many soft drinks. It's also in medicine. 150 years ago it was used as a sedative. It's still in all these medications right now. You guys have these medications, I'm sure, available. Yes? Spirivia inhaler. It's in household dust. Survey of 17 homes found high levels in all household samples. Just a few other things, and then we'll get to questions. Here's the World Health Organization for fluoride. So fluoride levels, let me just put it up. From 1960 or so to 2000, fluoride levels have been declining in all the unfluoridated countries as well as the fluoridated countries. You guys are 10%, I would assume, unfluoridated, is that right?
Yes.
10% unfluoridated.
No, 10% fluoride.
10% fluoridated. All right. Here's the fluoridated countries and the unfluoridated. There's no difference between the two. That's all nonsense. But I have a whole lecture on that one. There's fluoride in teas. Here's the fluoride content in many different teas. I'm getting to something I want to show you there. No, not that one. Okay. Now, I got a whole section in my book on iodine in the breast. And iodine's been shown to do apoptosis in the thyroid cells, as we looked at, as well as mammary cells. It's the same mechanism of the iodinated lipids. And we looked at that mechanism before. You guys do thermoscans? Is thermoscans available? What's the primary breast imaging thing? Is it mammograms? Are thermoscans covered by NHS?
No.
All right. So this patient first saw us here. And she's got to be 65 or so. And she's got some fibrocystic breasts. Send her for a thermoscan, which is read as TH4 and, high risk of cancer. And I had the guy who reads our thermoscan sort of outline it for me. We put her on 100 milligrams of iodine. And you can see the progression of her thermoscans over time. Here's 6 months later or so. I mean, it's almost gone except for little areas here. And now look, what is that, 2 years later? It's pretty much gone, and he changed the reading here to TH2, which is just basically a benign finding. And her lumps went away and all that. Oh, this is really cool. I just got this one too. You got to see this study. 12 human cancer cell lines were looked at, 1 non-malignant cell line. The cells were exposed to 10 micromolar of iodine for 2 days, equals about 50 milligrams per day. There's the calculations to figure out micromolars to serum levels. The cell densities were compared with controls. Look at the inhibition to the cancer cell lines of iodine at 50 milligrams per day. How neat is that? And why isn't this being studied? And the author said this research further substantiates the potential anti-tumor properties of molecular iodine and of iodolactones in breast cancer, as well as other cancers, and provides first evidences that this strategy may be extended to further human cancers. This was just released a month ago.
It's not being studied because it can't patent in that.
Right, you got that right. It killed a whole cancer industrial index that's built. That is from Experimental Clinical Endocrinology and Diabetes, 2009. This was like December. I just got this one.
Is that in the presentation we got?
No.
Yes.
All right. Let's finish with a case history and then a couple other slides, and then we'll take Q&A. 70-year-old female diagnosed with stage 4 inflammatory breast cancer. She declined conventional treatments, was given 3 to 6 months to live. I treated her at that time with vitamins, minerals, herbs, natural hormones. I didn't know about iodine. 2.5 years later, when I learned about iodine, I tested her and I passed through the testing. She was really low on iodine, high in bromide. 2.5 years later, I gave her 50 milligrams a day of iodine. Here's her breasts at start of treatment. So she took the iodine, calls me up 3 weeks later and says, I'm having a problem. What's the problem? She says, when I get up in the morning, my nightshirt over my breasts is yellow. I said, well, you better come in. She comes, and I said, bring your shirt. She comes in and brings a shirt. And I said, how do you feel? And she says, I feel better than I felt since the diagnosis. I'm taking care of my grandkids. I'm able to babysit them. I feel fabulous. These were her nails when I saw her that day, too. Bromine has this color to it. I'm assuming this is a bromide detox that she's going through. I left her on the iodine. She lived another 3.5 years, almost 7 years total, and the cancer killed her at the end. My regret with her was I didn't use enough iodine. I should have really pushed her levels up higher. I left her at 50 milligrams because that's what I knew at that point. Now what I would do is put her up to 100, 200. I put up 300 milligrams. The problem when you start getting up into these higher doses is it becomes expensive with these pills and unusable because you can go through a bottle every 2 days or something like that. At that point, you got to really search out Lugol's solution for them. At the higher doses, it's not going to work on the pills. For the vast majority of people, they'll work on the pills. Okay, so the adverse effects with iodine. You can have an iodine allergy. However, it's very rare. An allergy to seafood or shellfish is not an allergy to inorganic non-radioactive iodine. You could have one, but it means nothing about it. There's an acupressure technique called NAET. Does anyone do NAET? Very effective for it. We've treated a lot of patients with it. We've only had 2 or 3 patients over the years that we couldn't clear with iodine and allow them to take it if they had an allergy to it. Autoimmune thyroid disease. Now, I didn't get a chance to go through that. It's in my book. It's in your notes. Iodine was the treatment of choice for autoimmune thyroid disease before the onset of radioactive iodine. Its effective treatment dates back over 100 years. Iodine levels have fallen 50% over the last 30 years. Autoimmune thyroid illness has increased at a rapid rate during that time. If iodine deficiency was a cause of that, you would expect iodine. If iodine was a cause of that, you would expect autoimmune thyroid disease to decline during that time. That's not what's happened. Are autoimmune thyroid disease occurring at epidemic rates here?
Yes, but not just thyroid, all autoimmune disease. So what
Autoimmune thyroid disease, I'm asking.
Yeah, not all autoimmune.
Yeah, same with us too. I think it's because of this mechanism, it's iodine deficiency.
Not just thyroid autoimmunity, all of it.
Same with us too. Iodine's a detoxifying agent for the body. It's been shown to competitively inhibit these two things, but it's also been shown to push out, and this one too, it's been shown to push out mercury, aluminum, arsenic, lead, not in everybody, but in enough people that there's an old article talking about iodine and detoxifying mercury, and they called it a chaotropic agent, meaning just it pushes it out by an unknown mechanism. So to avoid detox reactions, nutritional support, get the pH up, healthy diet, have them do water, salt, liver support, whatever you're going to do. You'll see in the literature iodine-induced hypothyroidism and goiter. Nonsense. They cite Hokkaido, Japan. I don't even feel like getting into it right now. It's stupid. It doesn't happen. I describe it more in my book, and you have it in your notes. Iodine-induced hyperthyroidism. Now, this is something you might see over the years. I've seen 3 people over about 7 years. They have a hyperfunctioning autonomous nodule, and the nodule becomes hyperfunctioning when you give them iodine. It has happened. The only treatment in this case is you got to give them surgery to get the nodule out. I've had 3 patients in 8 years to me and my partners, thousands. So it's not very common. Iotism. If it's an ism, it must be a bad thing. But iotism, the bad iotism is metallic taste in the mouth, increased salivation, sneezing, coryzia, frontal sinus headache, and acne. None of these things are going to kill anybody. None of these things are going to make them too miserable. You can adjust the dose of iodine if you need to, give them more support. More salt can help this. The interesting thing is if you look at bromism, these are all part of bromism. Maybe there really is no iotism. Maybe it's all bromism. But whatever, the treatment for it is just support and back off a little bit with iodine.
What's the
1% thyroid cancer, 3 to 1 for women over men. If iodine was causing thyroid cancer, you would expect that thyroid cancer levels would be falling over the last 30 years in the U.S. It's not. It's gone up, and it's gone up here too, pretty much at the same rate from the numbers that I've seen. Radiation is certainly a risk for thyroid cancer. What are they going to give you if you have a nuclear attack on the island? They're going to give everybody iodine. Would they give the surrounding peoples and countries of Chernobyl when it blew? They gave them iodine. They gave them potassium iodide. Okay, so to minimize adverse effects from iodine, use adequate amounts of vitamins and minerals. Magnesium is really important. We went through that. Salt is very important to buffer bromine and fluoride and some other things. I now pronounce us cured of medical iodophobia. You are now free of this illness to tell other people about it and to use iodine in yourself and your patients. And I'm sure you'll find it in the same wonderful way that I found it. Just keep in mind, iodine levels have fallen over the last 30 years. During this time, all those illnesses have gone up. If it were dangerous for the above conditions, the incidences would not be rising over the last 30 years. Start slow, follow your patients closely, check levels, get ultrasounds before and after, and most importantly, combine it with a holistic treatment plan of diet, vitamins, minerals, detox, water, etc. Albert St. Georgi, the Nobel laureate, said, discovering consistency, seeing what everybody else has seen and thinking what nobody has thought. That's why we're here today. Make your own decisions. Think about what I talked to you about. Look at the physiology. Look at the biochemistry. If it makes sense to you, then consider using it for yourself and your patients. I'm sure when you look at the physiology and biochemistry, you'll come to the same conclusions I have. Thank you.